Hello everyone and welcome to the first lecture in the topic of ischemic heart disease, and we are starting this topic of course with the most important type of coronary artery disease, which is the ST elevation myocardial infarction. In this lecture we are going to learn how to diagnose STEMI and the different ECG patterns of STEMI and sequential ECG changes. Of course we are not going to discuss the management of STEMI in this lecture because here in the ECG course we are focusing on the ECG diagnosis rather than the clinical management. We need to remind ourselves with the definition of STEMI according to the ACE guidelines of 2017, and when do we consider ST elevation to be suggestive of coronary artery occlusion. According to these guidelines, the ST elevation measured as a J point is considered to be suggestive of ongoing coronary artery occlusion if at least two contiguous leads are showing ST elevation of more than or equal 1 mm in all ECG leads, except in V2 and V3, in which the cutoff point is different, because sometimes it's accepted to see some early repolarization pattern in these two leads per se. And so the cutoff point is 2.5 mm in males less than 40 years, 2 mm in males above 40 years, and 1.5 mm in females in absence of LVH or left bundle. And of course we know that the definition of new left bundle in absence of previous documented ECG of course is used to diagnose STEMI, and we are going to discuss the issue of acute left bundle in another lecture. We need to remind ourselves what are the steps of the pathogenesis of ST elevation. Of course the first thing when there is an acute occlusion of a coronary artery is an area of infarction in which there is coagulative necrosis due to cut of blood supply to this region. Surrounding the zone of infarction is a zone of injury in which there is like reversible degenerations of the myocardial muscle fibers, but it still can be salvaged, and around it there is an area of peri-infarct ischemia. Of course, if we intervene at a suitable time, we can help to salvage the three region, but the more delayed the management regarding primary PCI or thrombolytic, in this time of course the infarction can be irreversible, and this area of injury can turn to be infarcted as well, and then the zone of ischemia can extend and the zone of infarction also extends. So these are the pathogenesis of ST elevation regarding the steps which occur in the myocardium here regarding the STEMI. Let's explain the ECG sequence in ST elevation myocardial infarction. Of course there is a normal ECG prior to myocardial infarction and prior to coronary artery occlusion. Then ischemia from coronary artery occlusion can result in minimal ST elevation but in peak T wave, and sometimes the peak T wave, or we call it of course hyperacute T wave, may precede the ST elevation. And then if the infarction is persistent and the ischemia is persistent, in this time there is marked ST elevation and the ST elevation magnitude can increase, and then with ongoing infarction of course ST elevation maybe remains the same or sometimes may decrease, but with appearance of pathological Q waves and T wave inversion of course. Sometimes when we see these ECG changes, we may consider that the patient was in a long time in myocardial infarction, but of course these features should not dictate our management in order to abolish primary PCI. And then if all the myocardium was not salvaged, this leads to persistent Q waves with nearly recovery of the ST elevation and T wave inversion, and sometimes the T wave also recover into upright T waves. And if the myocardial infarction was not salvaged, there will be persistent pathological Q. So this is in summary the ECG sequence in STEMI. Let's at first discuss the first one, which is the ST elevation, and this is the most important side that takes our attention when we see in the ECG. Of course it occurs in the early stage in the leads facing the infarction. So for example, if you are speaking about a patient with inferior STEMI due to RCA occlusion, in this case leads 2, 3 and AVF, which are all unipolar or are limb leads. In this case the ST elevation will occur in these leads facing the area of the inferior wall of the myocardium. And of course we know that there is something called reciprocal ST depression, which is something like a mirror image for the ST elevation. It occurs in the opposing lead to those showing ST elevation. So for example, the same patient who had inferior STEMI and ST elevation in 2, 3 and AVF, he will have reciprocal ST depression in leads 1 and AVL, which are the high lateral lead, because this is like the high mirror image for this inferior leads or the opposing area. So this is called reciprocal ST depression. Reciprocal depression is very important to differentiate STEMI from pericarditis, as we are going to discuss in another lecture. So for example here, this patient has inferior STEMI. As we can see here, he has ST elevation in the inferior leads as well as ST depression in inferior leads, to ensure this patient has frank pattern of inferior STEMI. Let's move to the deep Q waves. Of course, the deep Q waves are one of the most important signs that occur in myocardial infarction. Should be used as only a diagnostic change that occur in myocardial infarction, not affecting the clinical management. The pathological Q wave are usually more than 40 milliseconds in duration, with a depth of more than 25% or quarter of the ensuing R wave. But of course, they have solid criteria for diagnosis according to the fourth universal definition of MI in 2018, which defined them as any Q waves in lead V2 and V3 more than 20 milliseconds or complete QS complex in these two leads, Q waves more than or equal 30 milliseconds and more than 1 millimeter depth, or QS complex in any of two contiguous leads in 1 AVL, V1 to V6 or 2-3 and AVF, or even R wave more than 40 milliseconds in V1 and V2 with RS ratio more than 1, and concordant and positive T waves in absence of conduction defect. So here, for example, in this ECG, this patient had anterior STEMI, of course, as we can see from this residual ST elevation in V2 to V6. And of course, we can see evidence of pathological Q wave, which are here more than 40 milliseconds. And of course, the depth here is more than 1 millimeter in the ECG leads. And so we can consider them to be pathological Q waves with residual ST elevation in these patients. Here, of course, this example, this patient also has an evidence of pathological Q waves in inferior leads. Here we can see that the duration may be more than 30 or 40 milliseconds, and here the depth of the Q waves is nearly 1 millimeter or more than 1 millimeter in lead 3, for example, and they are more than quarter of the length of the R wave. So these are pathological Q waves in inferior leads. Remember, pathological Q wave usually indicates to many clinicians a sign of all healed MI, and this is completely wrong. They can start to appear in patients with acute myocardial infarction like STEMI or non-STEMI, and they should not be considered as a sign of completed MI and should not prohibit urgent revascularization. So please, if you see pathological Q in a patient with a STEMI, this doesn't mean that the patient doesn't deserve to have primary PCI because he have completed myocardial infarction. No, they are not a sign of complete myocardial infarction. If the patient has still chest pain, he should be urgently transferred to the cath lab. And that's why, of course, we abolish the MI classification of Q wave and non-Q wave and being replaced with STEMI and non-STEMI, because presence of pathological Q can occur in STEMI and also in non-STEMI, and this doesn't necessarily indicate old MI. Let's now move to the T wave changes. Of course, we know that the T wave, of course, may be the earliest sign of STEMI. It can be lensed or heightened by ischemia, leading to the appearance of hyperacute T wave, and then T wave inversion can be a late change in the ECG and tending to appear as the ST elevation is returning to normal or reducing in amplitudes, and the ST segment returns towards the isoelectric line. Then the T wave can decrease in amplitude and eventually inverts, and at last it may revert back to normal after many days. So T wave changes are one of the most important signs in ECG. We remind ourselves with the rules of the T wave amplitude. It is measured from the baseline to the peak of T wave, and it is proportional to the QRS amplitude to be less than 2/3 of the R wave and more than 10% of the amplitude of R wave, and usually it decreases slightly with age. And of course, we know that it is usually less than 5 millimeters in LEM leads and less than 10 millimeters in precordial leads. This lecture, of course, was the lecture of ECG interpretation at the start of that ECG course. So here, for example, we can see that this patient have hyperacute T waves, and so even in presence of isoelectric ST segment, I can consider this patient to have an early sign of STEMI, and if I repeat the ECG after about 10 to 15 minutes, I can find STEMI. And so if the patient has a STEMI or patient has typical chest pain, I should refer him for primary PCI. So hyperacute T wave may be the earliest sign of STEMI, and here of course is more than 2/3 of the complex amplitudes. Here of course in this patient also we can see that this patient had hyperacute T waves that may precede ST elevation, but this patient have another pattern of STEMI, which is called Winter syndrome, in which there is ST depression in V2, V3, V4, 5, and 6 with hyperacute T waves. So this pattern is equivalent to STEMI. And so this emphasizes the importance of hyperacute T wave. Hyperacute T wave may occur with other patterns. So sometimes the morphology of the T wave may differentiate. For example, if it is symmetrical, narrow-based, and pointed like it is sharp at its peak, at the time, most probably it is due to hyperkalemia. Whereas in myocardial ischemia, it is usually symmetrical, broad-based, and not pointed. So of course, this is a differentiating point for them. And of course, the normal is asymmetrical and not narrow, and this of course is the normal variant of T wave, or the normal pattern of T wave. When I see deep symmetrical T wave inversion, of course this is a very critical sign for myocardial ischemia, because T wave should not be symmetrical, always it is asymmetrical. So here of course we can see that the T wave are deep, more than 5 mm depth, and this signify myocardial ischemia. So this patient in presence of deep symmetrical T wave inversion, which we call Valencine, as we are going to discuss later, this patient can be considered having high risk myocardial ischemia because of the symmetrical T wave inversion. Whereas the asymmetrical T wave inversion, in which the ascending slope is more steep than the descending slope, this can occur as a secondary repolarization abnormality with ventricular hypertrophy or bundle branch block. So of course there is a big difference between the two. So remember, subtle change in T waves are often the early sign of myocardial infarction, and in 20 to 30% of patients presenting with MI, T wave inversion or T wave changes are the only ECG sign, and patients with typical chest pain and hyperacute T wave should be taken seriously. Please don't say the patient was having isoelectric ST segment, so I should not consider him STEMI. No, hyperacute T wave may precede ST elevation. And remember, symmetrical T wave inversion are almost always a sign of myocardial ischemia. Let's see here the ECG evolution with successful reperfusion. This patient was having normal ECG, and then he have acute coronary occlusion leading to hyperacute T wave followed by frank ST elevation within hours. Then with successful reperfusion either by primary PCI or thrombolytic, the ST elevation reduced in amplitude more than 50%. The T wave were slightly hyperacute as before, but it is less in amplitude. And then with 2 to 5 days, the ST elevation is nearly returning to normal with T wave inversion, and then weeks later, it returns back to normal regarding the ST segment and T wave change. Whereas with failed reperfusion due to omitting the optimal therapy, the patient will have the same ECG change as before, but he will have pathological Q, and the ST elevation may decrease, but with developing T wave inversion. And then if there is no any element of reperfusion is performed, the patient may develop pathological Q wave with nearly amputation of the R wave and T wave inversion, and weeks to months later the ST elevation returns to normal, T wave returns again to be positive, but with persistent pathological Q waves. Let's now remember the anatomic groups of the ECG leads. We remember of course the schedule which we use in the basics of ECG lecture. And we remember which leads to call inferior, which leads to call anterior, and the anterior leads of course we divide into septal, anterior, lateral, and so we can now define any pattern of ischemia according to which ECG leads are showing the ST elevation. So for example, if the ST elevation was caused by occlusion of left anterior descending, it will cause ST elevation in that chest lead from V1 to V6 for example, and in this case we are going to call it Anterior STEMI. So Anterior STEMI can present for example with ST elevation from V1 to V4, and so in this case we can call it Anteroseptal STEMI because V1 and V2 are always opposing the interventricular septum, and V2, 3 and V4 are opposing the anterior wall. Then ST elevation from V3, V6 for example, we can call it anterolateral because V5 and V6 are almost opposing the lateral wall. So from V3 to V6 we can call it Anterolateral STEMI. Whereas ST elevation from V1 to V6 is called extensive anterior STEMI because it's involving nearly the whole anterior wall, and it indicates a grave prognosis as there is very proximal occlusion of the left anterior descending. So for example, this patient, we can see here that this patient has ST elevation from V2, 3, and nearly in V4, so we can call it Anteroseptal STEMI. And in this patient, we can see here that the ST elevation is extending from V1 to V6, and so we can call it extensive anterior STEMI. This pattern here, it occurs when there is an occlusion of RCA or sometimes with LTX. And here we can see the ST elevation occurring in lead 2, 3, and AVF, so we can call it inferior STEMI because it's opposing the inferior wall. So for example, here we can see the ST elevation in 2, 3, and AVF, and so we can call it inferior STEMI. Then we can see here that if there is an occlusion of the LTX or the OM branch, ST elevation may be restricted, for example, to V5 and V6, and so we can call it lateral STEMI, or sometimes to leads 1 and AVL. So for example, if ST elevation is only in V5, V6, we can call it lateral STEMI, and I expect LC exclusion. ST elevation can be present in only one AVL, so we can call it lateral STEMI, or to be more specific, high lateral STEMI, and so I expect OM or diagonal branch occlusion to be the culprit artery based on the pattern of ST elevation in these two leads. So here, for example, we can see that the patient has ST elevation in one AVL, and of course there is reciprocal depression in inferior leads, and also we can see here that this patient, we can call it lateral STEMI. Sometimes when we see ST elevation in lead 2, 3, and AVF, so it is inferior STEMI, and as well ST elevation in V5, V6, and or 1 AVL, we can call it Inferolateral STEMI, and in this case I expect dominant LTX versus dominant RCA occlusion. So Inferolateral is like a combination of ST elevation in inferior leads and ST elevation in lateral leads. Here in this ECG, we can see that the patient has ST elevation in the inferior leads as well as ST elevation in lateral lead V4, 5, and 6. And so we can call this patient that he is having Inferolateral STEMI. Of course, we should not forget that in patient with STEMI, we should not only depend on the standard 12 lead surface ECG. There is something called RV infarction, which usually occurs with inferior STEMI is the RCA occlusion occurs before the RV branch. And the ECG signs, of course, of RV infarction are very important to recognize. Of course, the most important of them is the right ECG leads showing ST elevation in V3 and 4 and 5 right leads, and ST elevation in lead 3 more than ST elevation in lead 2, the magnitude, of course, of ST elevation. And sometimes it is not uncommon to be seen ST elevation in V1 alone with the inferior STEMI. Of course, we remember that the ECG leads of the right ECG distribution are nearly the mirror image to the standard left ECG. And we remembered from the first lecture their anatomical location. Here, V1 in the fourth intercostal space to the left side of the sternum, then V2 to the right side, V3 in midway between V2 and V4, V4 will be in the fifth space mid-clavicular line, V5 at the anterior axillary line, and V6 at the mid-axillary line. Here, let's see in this patient was having right ECG leads in order to exclude RV infarction. And as we can see here, this patient is having ST elevation in V4, 5, and 6 right ECG leads. So this is a sign of RV infarction together with the inferior STEMI. Here in this ECG leads, we can say ST elevation in the inferior leads with reciprocal depression in 1 AVL and also in V5, V6. But there is an important sign with the circle pointing to ST elevation in V1. Of course, the ST elevation here in V1, which was more than 2 mm with Q wave, it indicates transmural MI of the anterior wall of RV. So it is not a sign of anterior STEMI. And the absence of ST elevation in V2 and V3, of course, rule out anterior MI. So presence of ST elevation in V1 together with the inferior STEMI is a sign of RV infarction even before doing the right ECG leads. Here in this ECG, we can say that this patient is having ST elevation in the inferior leads and reciprocal depression in lateral leads, together with the ST elevation in V1 and extending as well to V2. And so this can be considered as a sign of RV infarction because it indicates transmural infarction of the RV anterior wall, as well as the ST elevation in lead 3 is much more than the ST elevation in lead 2. And so I can assume even before performing right ECG leads that this patient is having inferior STEMI with RV infarction, and it is not combined inferior and anterior STEMI. Of course, let's not forget the posterior infarction that can occur with RCA or LCA occlusion, and it indicates that there is ST depression in V1 to V3 more than or equal 0.5 mm with tall R wave. Of course, this is an equivalent or ST elevation or like a mirror image or reciprocal depression to the posterior leads, and so I can confirm this by putting posterior ECG leads V7, 8, and 9, detecting ST elevation more than or equal 0.5 mm. So we can see here that the posterior chest leads here are put on the back of the patient to the left side in order to diagnose posterior STEMI. And if we can perform an ECG here, we can see that these posterior leads, which are equivalent to V7, 8, and 9, showing ST elevation diagnosing posterior infarction. And the cut point here is 0.5 mm, not 1 mm. When I see that the patient has ST elevation in 2, 3, and EVF, so we have inferior STEMI, and ST elevation in V5, 6, and or 1 EVL, so he has lateral STEMI, and he have ST depression in V1, V2 with tall R wave, and so I assume that he has posterior STEMI. I can call this Inferior STEMI, expected to be dominant LCX or dominant RCA occlusion. So here, for example, I can see that the patient is having ST elevation in inferior leads and in lateral leads, and also he's having ST depression in V1, 2, and 3 with tall prominent R wave. If I perform it for this patient posterior ECG leads, they are going to show me ST elevation, and so this patient is having Inferoposterolateral STEMI. And so remember, of course, the higher the magnitude of the ST elevation in millimeter and the wider the spread of ST elevation ECG leads, the worse the prognosis of STEMI. So at the end of our lecture, we understood today how to diagnose STEMI, we understood the sequential ECG change of STEMI, and also we understood the nomenclature of the famous sites of STEMI when to call it anterior, inferior, anteroseptal, inferolateral, inferoposterolateral, and we remembered also here how to diagnose RV infarction and posterior STEMI and how to arrange or put the ECG leads for them. So, of course, our take-home message today, T-wave changes may be the early sign of STEMI, even with the ST segment is isoelectric, and pathological T waves are not considered sign of completed MI and should not omit primary PCI, and never omit posterior STEMI and RV infarction from your diagnosis. Thank you very much for your watching.